Good evening, all. Thank you for joining us today. My name is Ibrahim Fahdi. I'm from First Coast Cardiovascular Institute. As we all know, that we're going to talk about heart disease and COVID-19, mainly focus on the current pandemic. So this is my first slide. I cannot put that to address whether or not the COVID-19 that we're dealing with is simple or a complex problem. You know, there's a lot of time, there's bad things can happen. You want to be prepared for it. But every day you delay it. And then when the bad things happen, then you would try to make things easy and you hope you're going to go away fast. The problem is like what we have with COVID. It become really a major issue that this poor healthcare provider getting on a ladder, tried to fix this problem while his colleague down there tried to help out. Not really a lot of tools to help fixing this network. The good thing that we all gonna be together, and the good thing that we have similarities of prior disease pattern that kind of taught us lessons so we can move into the future. The problem, it's gonna take a little bit some time to get things getting better. So why we focus on the COVID? You know, as healthcare providers, we always like to have a benchmark. And one of the benchmark that we depend on is, are we really successful in taking care of people? And the mortality rate is one thing that we try to aim to minimize and reduce as much as possible. So if you see in this busy slide, or you look on the right, that you see that in March 22nd, the mortality associated with COVID-19 was fairly dismal. Heart disease, still the #1 killer in the United States, and then cancer, and then the whole list. Slowly, gradually, within a month, almost the COVID-19 caused the most mortality in the United States. That is really fast. I think we all, or at least most of us, I know I'm one of them, had the app on my phone from Johns Hopkins dashboard, try to track on a daily basis the number of cases across United States, the states, my state, and nationwide, and of course for the colleagues who had family or friends all over the world, just kind of know what's going on. And the numbers has been exponentially increasing like crazy. So for us, we try at the end of the day to take care of patients. And then we got a lot of data. Some, which we're gonna talk a little bit more in details, don't use ACE inhibitor. And then use ACE inhibitor. Don't use Motrin. Then don't use Motrin. So there's a lot of things. And if you look at PubMed, and if you look at all the ACC, AHA, CDC, NIH, FDA, whatever you want, you see that the update has been almost on a daily basis. So that's gonna get us in a situation that really can let us step back, know a little bit more about a disease so we can take care of it with available tools that we have. So what I kind of thought with the team that really helped me out to get this up and running with you all, that to focus on the presentation to make it a clinical-based presentation. And unfortunately, we have to go a little bit about the virology and learn from the fundamentals or refresh our mind about it, talk about epidemiology, and then how the clinical presentation for the disease, and talk about the updated diagnostic, armada we have, management, and talk a little bit potentially about the long-term implication. Please note that the information I'm gonna provide you, it's been updated as much as I can from the ACC, the FSE, all the other FASE, and from the other kind of societies. But things can change and can change very fast. So to look at the fundamentals, if you look at the virology, truly the coronavirus is something we had for a while. And as you know, there are 5 groups: alpha, beta, gamma, and delta. The gamma and delta are the two really have not been proven that affect the human directly. Alpha and beta are the most common. Of those beta, there are 7 types. 4 of them that cause 15 to 30% of what we call it the upper respiratory tract infection, and usually those are self-contained, rarely to cause a major problem. There's 2 that were notorious, and now the third came out. The first one, what we know is the severe acute respiratory syndrome coronavirus that caused the pandemic in November 2003. And then the second one is the MERS, which is Middle Eastern Respiratory Syndrome, that caused mainly in the East and Saudi Arabia in June 2012. What we know about those viruses, that they need a host. And a host in SARS, for example, in 2003, that the Chinese horseshoe bats, and then to the Himalayan civet and the raccoon dogs, and then get to the human. The MERS, it was the camel with the host, and then went to the human. And then from the human can infect other human and transmit directly with a different trait between those viruses. The good thing that there's some lessons we learned from the first SARS that can hopefully help us in taking care of with the new virus pandemic. So since there is like almost 60 to 70% some similarities. The MERS and the COVID-19 don't really have a lot of similarities. So if you look at those, the most common viruses, the first line is the disease. So COVID-19 is the coronavirus disease 19 by the year 2019 is the disease. It's caused by the severe acute respiratory syndrome coronavirus 2, since the SARS caused by the CoV-1, and the MERS is by the Middle Eastern Respiratory Syndrome. So when you look at the basic reproductive rate, which in a way that if you infect the person, that person, how many could infect? And you see the flu, 1.3, one can infect 1.3 person. The COVID-19 can infect or transmit to 2 to 2.5, the SARS and the MERS between 3, and the MERS 0.3 to 0.8. Look at the hospitalization rate, 2% for the flu, almost 19% for the COVID-19, most of the cases for the SARS and MERS. If you look at the bottom, that you see, since 2014, there's only 2 cases in the United States from MERS, 8 in the United States from SARS. We don't know much about the COVID-19, but as it's going very, very fast. So it might take us a while before we have a little handle on it. If you look at the annual infected number in 2003, the SARS was almost 8,000 or 8,100. MERS was around 420. Focus on the 2 similarities, back again as a summary. Since SARS-CoV and SARS-CoV-2, there's almost, like I said, 60, 70 similarities. It gets from the bat, need a host. And then from the host, go to the human. And usually the host in, like, the wet market in China, that can wet to the animal, and then a human. And the human go in and could infect other by droplet, by leaving them on surfaces. The good thing, as you see, and hopefully can give you a little bit some optimism, that the way that infect the human cells is through the angiotensin converting enzyme 2 and get primed by temporal SS2, those where you have the most of the treatment and most of the research try to attack those 2 and hope they can help us to take care of the new pandemic. We all seen this slide in the past multiple times, and I'm showing this because the importance of it, and that what created a little bit some of the confusion of whether or not we could use the ACE inhibitor, the ARB, or not in this pandemic. So the angiotensin get converted by the renin to angiotensin 1. Angiotensin 1 converted by the angiotensin converting enzyme to angiotensin 2. Angiotensin 2 attached to the AT1R, which cause a lot of inflammation, fibrosis, oxidative stress, cytokine storm. People. The way the body will defend or try to balance it out is by changing to the endopeptides to angiotensin 1 to angiotensin 1,7, and the angiotensin converting enzyme 2 to angiotensin 2 to angiotensin 1,7. What that does, the product angiotensin 1 to 7 attached to the receptor MAS-R, which cause anti-inflammation, antifibrotic, nitric oxide release, and faster relaxation. The problem that we had with SARS-CoV, the original, and SARS-CoV-2, which is single-stranded RNA, is attached to the enzyme ACE2. At that case, neutralize it. So you don't have anymore the anti-inflammatory, antifibrotic, the nitric oxide release, and all what we're stuck with is the inflammation, fibrosis, and oxidative stress add to the vasoconstriction, which can make us prone, depends on our genetic predisposition to various ways to react to the SARS-CoV-2 or affected by the COVID-19. Don't worry about the first slide, the first part of the slide, but you look at the immunopathogenesis and the end organ, you see there are a number of cytokine and the effect that it causes. Those are the one, the ILN1 beta, the interleukin 2, 4, 6, TNF, all of those are target, as I'll show you eventually, a long list of target in hope that can neutralize and can affect and minimize the response of the cytokine storm, which cause to increase the mortality in our affected patient. So, back again, the first COVID-19, the disease case was reported in January 2020. There are some data show that could be even earlier than that, maybe back in November. And again, depends on which resource you look at and depends on the time you look at those resources. We are getting updated and informed more frequently. As of April 22nd, our cases were around 2,628,000. I looked at it a few minutes ago, we are around 2,660,000. So the numbers exponentially increasing. The highest risk population, people with hypertension, cardiovascular disease, COPD, cancer, renal disease, obesity, and the one had autoimmune, they are more exposed to the risk and to have higher morbidity and mortality from the pandemic. To get back again narrow and to show why it's important what they've been doing in educating the public about the social distancing and the hygiene that we should have been, but we're not as much as we did, and now we pay more attention to. They estimate how many people will be infected by the flu is 1 to 3 from each one infected. From the COVID, each person can infect 2 to 2.5. The incubation, it's almost 1 to 14 days in the flu. The average for COVID-19 is 5 days, but can go up to 2 weeks. Hospitalization rate is 2%, and for the COVID-19 is 19%. What is known that beyond the slide I showed you that the rate to infect person to person is around 0.5%, but for the person who has been infected, there's around 10.5% chance to infect the rest of the family members. So it's serious business when one gets infected, how fast it can affect the others. The mortality, as you see, is 1% or less on 1 to 3, 4-point and depends on which location, which area, and what type of people. But in general, that's the range of the fatality rate. So then when we look at it, say like, you know what, the percentage is not that high as we were afraid of. So why are we making too much deal of it? Remember that I showed you there's worldwide, there's around 2,600,000 and increasing. Look at the speed that the virus go through and the mortality rate. That goes to, if we get on the red line, that most of people get infected, sick, what's gonna happen? They're gonna go to the hospital. They're gonna take most of the bed in the hospital. In that case, what about our resources? What about the other patient in dire need to get treated from COPD exacerbation, from a myocardial injury, from other disease pattern? They're almost going to be competition on those beds. What about the healthcare providers? And I'm not talking about physicians. I think we need to look at healthcare providers from the respiratory therapist to the nurses, to the technician, to the technician who do echocardiography, to the x-ray. We all in the same boat, because the people who do echocardiography, they would know when the sonographer go and do the echo, it stays with the patients, almost touching the patient for almost 30 minutes to 40 minutes. That close contact could create a problem. Social distancing in a way that to minimize everyone gets sick and to get them flooded to the hospital, in a way that to minimize the infection rate, in a way to minimize the mortality, and to give us a little bit some time to can pull back those old books that we learned from the SARS to come up hopefully with therapy, appropriate therapy, and to a vaccine, so it can help minimizing the risk, as you see in the blue line, for the resurgence, since everyone start getting a little bit impatient or frustrated or want to get back their life again. So that's the reason is for the flattening the curve that everyone we're talking about is to save, minimize, and to be able to slow down so we have a better therapy and vaccination for the future. So what will happen, and most of the people who work in the medical field, and especially the cardiologist, this is a paper from Dr. Krumholz and published in New York Times. Truly, we don't see anymore that patient coming in with STEMI or with the ACS at the hospital. Elderly and other part of the population, they're trying to shy away from the hospital because they're afraid they might get infected. They're afraid that they might die. There's a little bit some vague when we get the information out of the public. So truly, people go to the hospital only if they need to. And the heart attack, reducing the number of people showing up to the hospital doesn't mean COVID-19 cured CVD. It basically forced people to stay at home and minimize their exposure to the hospital. And you could see that even in your clinics and our clinics, that the number of patients showing up is less. So back again to address that the incubation period can go back up to 14 days, but on average, it's gonna be 4 to 5 days. Understanding from the early data from China, the first 72,000, almost 81% of the people have been affected, they're gonna have mild disease. That quarantine, be it at home for 2 weeks, they should in general overcome the disease and go well without a major serious side effect. 14%, they have severe reaction, and 5% critical. They end up between the severe and the critical on the ventilator for a duration of time. And average depends on the resource that you look at it, 10 plus minus few days. The most common presenting symptoms, and that has been changing very, very frequent. That fever, 85%, shortness of air, 80%, diarrhea, 27%, and nausea. Why is that? Because the CEA2, the angiotensin, the angiotensin converting enzyme 2, basically in multiple organs, that they have upper respiratory and the GI tract and the myocardium, in other places, that whatever that virus can attack the ACE2, that can affect the receptor. When you look at it, this is another one, and then the more, this is updated in April 2nd, give you that sore throat. Sometimes, initially we thought it's gonna be most of the time. That changed a little bit. Sneezing, stuffy nose. That keep updating because we are getting to know more and more about those, about the virus and the way that affecting us. Recognizing that each community and each country can differ in a way that they react to the virus. Another, flyer, there's some similarity and a difference. The point from multiple of those is to show you that we were in a way that learning about it, and we start constellation those symptoms, and I wouldn't be surprised in 1 month there's gonna be something else coming up. So to look at from the 150 patient that admitted to Wuhan, this is initial data that you have. To look at the numbers to give you a little bit more precise, that 68% died and the rest, they were discharged. 35% of them of the died from respiratory failure. There's a mixed respiratory cardiac, there's myocardial damage, and there's some percentage, almost 5% is not, or 7%, 5 patients not known yet. Heart-wise, there's wide variety of damage that the virus can cause us. Eventually, can cause either thrombotic with myocardial damage due to coronary artery disease, either unstable plaque to decrease in myocardial oxygen and break the balance, to direct effect on the myocardium with myocarditis, to the arrhythmias. That's wide range. We know a little bit about it, but I think it's going to take a little bit some time to understand. And the bottom line coming from it, that cascade of the the storm and the inflammatory markers, all those can cause multiple damages, and that effect on the heart can varies from person to person. So what we do is, when we get a patient, it's good to have a detailed history. It's good to know whether or not they travel to an affected area or they've been in close contact with people who've been traveled. Unfortunately, initially, people who traveled and they carried the virus and they were infecting others without people knowing. Fortunately, the minor percentage, they knew that they were infected, but they traveled. And we know about those couple of those cases on the news. From China, we know that 80% of the infection occurred by carriers, not by people who truly been symptomatic from the virus. The way I kind of look at it is good that when you have those patients give you the symptoms that I already shared with you, that to be suspicious. I don't think it is bad to consider everyone is COVID-19 positive till proven otherwise, in a way that to protect the team and to be sure that minimizing the transmission. The CDC, as of now, recommend nasal swabs or the oropharyngeal swabs. Initially, it took 5 business days to get the results. Lately, and it depends on the area, we can get the results within the same day or within 24 hours. There's some more platform available. I want you to look at the bottom, the last line, that emergency use authorization. There's around 30% false positive give and take with the available platform. There's some were very promising to look into antibodies, but my reading, a couple of days ago, just an update that from China, there's only small percentage that they represented with antibodies production. Opposite was the hope that we have high percentage of people with higher percentage of antibody production, in a way that the second wave, which everyone was concerned that it might be higher chance to cause more damage, since as of now, the antibodies reproduction is less than anticipated. Chest X-ray, it's been helpful, and you see from the right with the A and the B, how fast the pulmonary damage can cause to the lung. And eventually we get, some of the patient might get the ARTS, and you know how much bad prognosis that carry. What about the CT? I think that the CT has been more helpful from my reading and from seeing in our hospital than just a pure X-ray. The ground glass opacification, you see it in 88%. Bilateral involvement, almost 88%. Posterior distribution, the consolidation, you see 32%. There's some pattern on the CT that help the radiologist to be specific, and I see that more often now, that could, simulate potential COVID-19 positive, so that can alert the team to address looking at the titers and do the testing, versus, this is just pulmonary edema, or this is just purely congestive heart failure exacerbation. Not to forget that there still could be a mix between those cases, but at least as initial, it can help to differentiate and to redirect our resources and attention. As you see here, the early phase, how do you have the ground glass, which is a little bit more in a lighter kind of spots you see, and there you see some of the line, which is the fibrosis. And here you see the fibrosis with the yellow arrows, and you see how those kind of ground glass is a little bit more disseminated and getting a little bit in the larger, and the green, you see some of the consolidation. So we talk about getting the history. I'm going to share with you a little bit about the lab, but I talk about the X-ray, we talk about the CT. What about echo? With the way that we looked at the potential myocardial disease associated with the COVID-19, do we do echo on everyone? Do we need to do a full echo on everyone? What things and what strategies we need to know and to do? Again, for the people who deal very close with echocardiography, technician or physician or nurses, they would know that to do a full study, to do a really good job on healthy, be able to move around, respond to you, it's around 30 minutes. If you have a sick patient on the ventilator, it might take a little bit more to get a little bit more appropriate image to come up with diagnosis. So the American Society of Echocardiography kind of come up with some algorithm, call it POCUS, point of care ultrasound. And that diagram, in a way, it's very simple that you get, depends on the disease suspicion or suspecting they have the COVID-19. You do the POCUS. The POCUS can give you some points, we're gonna show you in a bit. If you feel that you get the information you need, then that's good. If that you don't, then you do the full study to get more information. But you also need to think of whether or not the echo gonna add any information to the already known information about the patient. If the echo not gonna add any more value, then do not really expose the healthcare provider unnecessary for the infection. And those are kind of the one that they look at certain selective, to look at the parasternal, to look at wall motion, to look at the IVC to give you in a way idea about the volume status, to look at the lung consolidation, pleural effusion. So all of those can have been helpful as a focus. You focus more, you expand more, depends on the clinical situation and the likelihood that the patient has or does not have the need for the full study. One thing that it kind of got my attention, and I shared that with you, this is kind of the calculation, the H-score, is to look at, is to look at the cytokine and to see what is the likelihood that patient gonna carry poor prognosis and how sick is the patient. And if you get, based on that algorithm, 169 points and higher, that will give you around 93% sensitivity and 86 specificity. So that's kind of tools I can learn from it, and I can try to apply it and to get us the likelihood that the patient not going to do well, and then what we need to do a little bit further. Again, I put those on the side: IL-1 blocker, interleukin-1 blocker, and IL-6 receptor blocker. Those two medication has been under the investigation for potential helping minimizing the injury associated with the cytokine storm for those patients. NIH came up with an algorithm, and they got a panel of 19, the COVID-19 panel, and that's kind of representation from several of those societies, as you see. And they come up with certain guidelines to help us to see what we need to do based on our current knowledge. If you have letter A, B, C, A, that you have strong support. C, it's in a way good to do. The 1, 2, 3, 1, the Roman numeral, that if you have at least one randomized trial. 2, at least you have a good study. Or 3, this is the expert opinion. And I put those in a little bit, some of those that has been circulated. And again, there's certain things that we are using in the hospital, such as the hydroxychloroquine and the Zithromax, but this is what been recommended by the panel, that there's no sufficient data to use for the hydroxychloroquine or the Zithromax, and this is A3. They reported that if you are going to use, you need to pay attention for prolonged QT, QTC to minimize the risk associated with it. And some of the hospital, we use those protocol because you end up seeing that the patient is dying and dying, and we don't have any other, and in hope those medication can help. Truly, I've seen some cases turning around. Now, can I say it because of this protocol? I don't think anyone knows, but I don't think that people can just use what we have in our armada and not to try to use something else like the hydroxychloroquine and Zithromax combination to help patients. They talk about the HIV protease inhibitor, that also there's no data to support the use for it. It came about, maybe they'll be helpful. They did not recommend for it. Remember when we talked about this slide much earlier, there was some conflict data and conflict the recommendation earlier about using or not using ACE inhibitor or ARB. As you see, that the ACE2, the angiotensin receptor converting enzyme 2, it's a helpful enzyme to counter-effect the angiotensin effect AT1R association and causing the inflammation. But if you use the ACE inhibitor or ARB, you could upregulate the angiotensin converting enzyme 2, which would give more potential entry to the virus and cause more damage. So initially said, do not use the ACE inhibitor or ARB. But then we have a lot of data. You have a lot of patients with heart failure, we have hypertension, you have diabetes. So what the recommendation was that if the patient has been on ACE or ARB and a need based on the guideline for congestive heart failure, please use it and do not stop life-saving medication, because as of now, we do not have a true evaluation or true study to show that those medications are harmful. But again, this is debatable. Things could change in a month or two. The same thing on Motra or the NSAID that came out. Do not use it, because using the Motrin, you would upregulate the ACE2, and that could increase the receptor and the enzyme that can get the COVID-19 disease or the access for SARS-CoV-2 to the body. Back again, they changed the statement, said you can use it, but you have to pay attention and only use it if you truly need it. Please do not try to read that. Just gonna tell you what all those interleukin with the inflammatory marker, there's a lot of studies they are undergoing, and hope that we can get some answers. What we learned from SARS, but we did not prepare completely well as we hope to do. Still, SARS give us some information, since there is some similarity with SARS-CoV-2. So all those options are available, and to see how much benefit, and hopefully we'll have some good results soon. Back again, those are the recommendations from the panel about what medication use and what not. Truly has been limited armada as of now. If you have a patient with hypertension, using the levofat, it will be helpful to help in stabilizing the patient. Try not to overgive volume, because could exacerbate the respiratory insult and worsening the shortness of breath. The prone technique, which is something I kind of learned from my colleague, the intensivist, having the prone for the high-risk patient and the patient with severe response to COVID-19 can help. If the patient does not respond well or could not tolerate the prone technique initially, do not stop attempting again, because the patient could tolerate again. High flow oxygen has been recommended. Very careful not to use any things that can spread the droplet out for the team and in the room. So all of those, what has been given recommendation, medication in particular, not yet. Hopefully we'll have something soon. What about the STEMI? This is something that's published a few days ago. And that's in a way, while we all been pushing door to balloon, while we all try to get things fast for the patient, the data is very, very, very solid in regard to take care of those patients. Get back again that we need to look, and we need to be careful and not to miss the need to be vigilant, but at the same time fast in addressing the history physical exam. If there is likelihood, what is the likelihood this patient can or maybe have a COVID-19, SARS-CoV-2? If there is a test can give you fast result, that would be great. If not, then we just need to have a discussion. ER, cardiologist, and expedite depends on the finding for those patients. Whatever the patient gonna go, it's always good to have an ICU isolation bed, especially as you see for the STEMI, and be careful in the lab, because that can contaminate the lab and can affect other patients who do not have STEMI if the lab was not cleaned in the way it need to, based on our new understanding for the droplet lasting on certain surfaces. Utilizing thrombolytics is back again for the patient in a hospital do not have cath lab or STEMI program, or can start with it and transfer the patient to the receiving hospital and address what next depends on the status of the patient. Echocardiography has been used in this to assist if you have a question regarding whether or not the patient does or does not have STEMI, when you have a little bit questionable in ECG, to address whether or not the patient has wall motion abnormality. The problem, if the patient already have coronary artery disease, already have an injury in the past, having an abnormal wall motion might not help that much. But if the patient have no history of coronary artery disease, having a wall motion abnormality can, in a certain situation, indicate there's a new true insult for the myocardium, not due to myocarditis, which is a direct effect on the myocardium, but due to coronary artery disease. The panel, and this is kind of to talk about each of the segment, ST segment elevation, cardiogenic shock, the decompensated heart failure, and heart transplant recipient. Again, for the heart failure patient, if the patient on ACE or ARB, please do not stop those medication. But at the same time, the recommendation was do not try to use ACE or ARB in non-guideline fashion to treat patient with COVID-19 because there's no data it can help. Only use it when the patient in need or known to have congestive heart failure. We talk about the ST segment, the cardiogenic shock, the role of ECMO with the circulatory support. It's still not clear. There's certain institutions been using it with some success. As of now, there's no data to show true help or actually the opposite. But I think when you are in a dire and you feel that patient is losing the fight, sometimes we just need to use with the good communication with the family and with the good close monitoring for the patient. So in conclusion, first, patience. Our knowledge is evolving. There's a lot of things we don't know and things are changing. It's good that we try to be updated. There's a lot of, like I said earlier, resources available for all of us with the ACC, AHA, the FDA, the CDC, all those, the American Society of Echocardiography also for about certain protocol. So all of those are available, and the updated information, you'll be surprised, it can happen on a daily basis. Very important again, that to educate the public about let's help each other to slow down the virus. Luckily, in Florida, we did not have, at least in Jacksonville, such much negative impact, but I know in New York, as you see, and others, been really hit very hard that they needed healthcare provider to travel over there to help. We don't want the same thing happen all over. I think learning from New York and the courage they did and the good things they did to take care of the population, hopefully that can help us take care of the other population in a different part. If there is a clinical trial and you have an access with the long list that I showed you, it's good that to participate and maybe can give the appropriate numbers to the participating studies and body in a way that can we shed light and give a little bit more data to help taking care of the sick population. While we're preparing to take care of the first wave, we need to keep in mind that potentially there is a second wave, and hopefully it will not be as bad as what we have initially. What about the practice? There's a lot of practices start moving toward the virtual clinic or telemedicine clinic. I think that can last. We've been using telemedicine since the 1990, and I think now it is the chance that telemedicine starts surfacing up and people are using it. There's too many platforms available, and the cost associated with it is much cheaper. It used to be in the past. Also, our patients love it. And when they don't want to go home, they don't want to go to the clinic, unless they really have to. For some of those patients, I've been using it in hospital too. So be prepared. That's something going to last. I don't think that's going to stop soon. The COVID-19 or the SARS-CoV-2, it's going to cause a long-lasting effect. Nobody knows what's going to be. But unfortunately, there's going to be no return back. But I think we're going to learn a lot of lessons from it. Hopefully, we can capitalize on the good lessons so we can move forward and to minimize the potential for the future pandemic. So that was my last slide. Thank you for all your patience and listening to me. Please, I'm available for any questions.
Thank you, Dr. Fadi. So if anyone has any questions, please either unmute yourself or use the chat box. And we already have one question, Dr. Fadi, from Dr. Garg. He says, I would like to ask the current best treatment / drug combinations that are being used to treat COVID-19 coinciding with cardiovascular disease.
There's truly no proof medication that they can help. What we have right now is related to the society relate. For example, congestive heart failure, you continue with the ACE or ARB, don't stop. If you need to have pressor support, that you can start with Levophed, potentially adding milrinone or dobutamine. There's really no magic medication. I know steroid been mentioned for certain selected number of populations, especially in setting of the myocarditis. The recommendation that do not use it, but just be very selective in the number or the patient that need to have it. But there was no really clean recommendation with the magic medication for COVID-19 and CVD as of now.
All right, thank you, Dr. Fadi. Linda asked, do you recommend POCU as soon as someone with CAD is diagnosed with COVID, or wait until complications begin to develop?
It's gonna depends on the hospital and depends on the clinical suspicious. If the patient does not give me the indication there's any myocardial involvement, cardiac biomarkers been negative, I wouldn't jump in the right away. I would wait, especially now that we can get the results within 24 hours to get whether or not the patient is confirmed, negative or positive, before I expose my sonographer to an interaction that truly the result is not going to help me making my change in my plan. And that's actually the recommendation too from the ASE.
Okay, great. Dr. Mindy asked, as you open the clinics, do you plan to test the staff and yourself?
I tested myself, by the way, and it took 10 days to get the results. Luckily, I was negative, and I think all of us initially, when you have the sore throat, you will worry about whether or not you're going to take the virus home, whether or not you're going to infect your family, knowing what the fast rate. So I did it, and it took 10 days. Luckily, I was not a negative, and it did not affect anyone. I don't know yet whether or not it will be having a negative results. That does not mean you're going to be negative. It means that at the time when the sample was collected, you were negative. 1, 2. But the things that we have right now, none of them has really great accuracy. So having a negative test that you still carry 10 to 20, 30, depends on who the manufacturer, where you do it, for potential false negative. We had a hope for antibodies, not there yet. So to test everyone in the office, I don't think that will be helpful. But if you have somebody can have some symptoms, absolutely yes.
Yeah, Dr. Fadi, and we do take all of the staff and patients' temperatures. So Dr. Rodriguez had a comment. Dr. Rodriguez?
Yes, so I want to comment. I just got a phone call last night. I have a cousin. She is a chief of pharmacy in a hospital in Brooklyn. And it's very interesting how the difference of what we're dealing and what they're doing in New York. So she was telling me that they have the hospital is about 250 beds, and they went in overnight. They went from 250 patients to 600 patients. She said that they were using freely chloroquine, Plaquenil, and Citramax, and they were so overloaded that they had no telemetry beds, and they were not doing EKG on patients. And she said a lot of patients suffer cardiac arrest, and she really thinks it was because of failure of monitoring the patients on these two medications. She said they start turning the curve around when they stop using that much of the Plaquenil and Citramax, and then she started full dose anticoagulation, which we're doing also now in the hospital, using Lovenox on these patients. And she said that's what started making a difference. So right now they still have about 200 patients, but they're 100% occupancy, and they're not as bad as it was like 2 weeks ago. They ran out of all the medications to intubate people, so they had nothing to intubate the patients. It was really awful. I mean, compared with what we're dealing here in Jacksonville, I mean, it's really nothing what they suffer there, but they learn a lot from their experience. But it seems like anticoagulation is kind of like the new scene now. So I don't know what's your comments regarding that.
Dr. Rodriguez, thanks a lot for your input. Definitely, we're gonna learn a lot from New York. I'm really sorry what happened over there, but their experience they're gonna help a lot. What I try to share is what is the NIH and the other society kind of recommended, but definitely there's a lot of hospital, including our hospital, using those combination with monitoring, because like I said, there's no yet a magic medication to help. In regard for the anticoagulation, I went back and I looked at it. And what the recommendation, if they just have DVT prophylaxis, they don't have recommendation that you do full anticoagulation for the patient. But if somebody has a sudden change in the status, somebody had drop in oxygenation or make it suddenly challenging, be very aggressive to look for potential DVT, PE, and looking at echo CT, ultrasound for the leg, and then go for anticoagulation. So by the society that I read, I see that they are not recommending yet full anticoagulation for everyone, but they're recommending that if you see any sudden change, do not wait for the next morning to try to evaluate. Be very aggressive, because time is going to be an issue for those patients. Thank you again for your interaction and your comment, Dr. Rodriguez.
Yeah, and Dr. Deneen had a question that coincided, or a comment that coincided with Dr. Rodriguez's comment. So Dr. Deneen?
Yes, I would just like to add there, Dr. Fadi and I have actually a shared friend that was in Brooklyn very recently. She's a pulmonologist, critical care physician who went to go relieve a physician there, and her go home take was very similar, but she said that a lot of the patients that appeared like they were ARDS on CT, when they did autopsies, didn't show ARDS. It was this very heavily thromboembolic process. Now, she was also dealing with the most critical of these patients. So I would agree that in these patients, if you see any suspicion of an elevated fibrinogen, which we're seeing in the sickest of patients, or these localized organ involved, neurologic, hepatic, cardiac, renal, that early institution of inhalation in the appropriate patient population would certainly, from what I've been getting in experience-wise, would be indicated.
Thank you, Dr. Deneen. One of the things that I need to add, that it depends on hospital to hospital. Some check creatine, D-dimer, interleukin, family, and they measure them, and they look at the series and the way that the pattern for those markers. Unfortunately, not every hospital equipped to do those. And some of the hospitals need to do send out. And if you're going to do those, it might take several days, that the value of obtaining them might not help that particular patient, but can help expanding the knowledge of how to take care of those. So there's a lot of things we're learning, and we're learning hard, but I'm hoping that we're learning fast too.
Thank you, Dr. Fadi. And Brenda
Do we have
asked,
other questions?
yeah, we have other questions. Brenda asked if you anticipate another wave this fall.
I am pessimistic. I am very pessimistic, and everyone said that the weather and it's going to be taking care of the sun and all this. Remember Tom Hanks? He was in Australia, and Australia was very hot at that time, and he and his wife get infected. Brazil at the same time too. So I'm not really buying the weather status and how things are going to affect the virus, and I'm afraid that we're going to have a second wave. There's a lot of impatience going on, and people want to get their freedom back, which I completely understand. I feel my family too, they want to get out of the home. But we don't have yet a tool, direct tool to help to treat, and we don't have a vaccine. So yes, if we loosen up early, we might get the higher chance we're going to have a second wave.
Okay, thank you, Dr. Fadi. And we have another question from Brian. Would you recommend that we take our patients off ACEI for those that are on it strictly for hypertension?
Based on the societies, no. If the patient has a low EF, if the patient only for hypertension and the patient has already been on those medication, don't stop them. If the patient only to gonna treat hypertension and they don't have diabetes, they don't have a low EF, you can use another modality to treat the hypertension. Don't start with ACE or R for those patients. Again, if the patient already have a low EF, have other factors per the society to use ACE or R, please continue or use, but don't start ACE or R for somebody. You could use another alternative and do not fit those criteria. Good question.
And then we have another question from Linda. If outbreak reoccurs later this year, will it be COVID-20 and so on for subsequent years?
I don't know. That's $1 million question. If she can figure it out and can't figure it out, we can split it half and half, or we can split it on all over. I don't know. What I'm afraid of, that hopefully it won't happen. I think we want to get our freedom. We want to keep our health and keep forward. There's a lot of people, health, economy get affected. So hopefully no more, but we just need to get ready.
Okay, and then Dr. Garg asked, do you think only vaccine will be the breakthrough? If we get through this, flatten the curve in each country, what will be the future once we open up our borders?
Oh, I think I appreciate your question. And I think vaccine is going to be important. A true vaccine that can be tested accurately, not just by giving an emergency and to be used on certain selected number of people and come up with a little bit fast release, and then we end up having an error. Good vaccine, good medication can help. We survived SARS, we survived MERS, we survived the Spanish flu, and I think we'll survive that. But I don't think anyone truly can give 100% answer at this point.
Any other questions, anyone? Going once, going twice, and that's it. All right, if you guys have any other questions, please feel free to email them to me. You guys will get an email tomorrow. If you need a CEU certificate, there will be a place to request that. And there will also be a quick, 6-question survey. So please take a minute to fill that out. But thank you, Dr. Fadi, so much for your input and your knowledge.
Thank you, and have a good night. Please stay safe, and it's going to be okay. I hope this presentation was not too gloomy, but it is just part of the reality. But I think in a few months, we're going to look back and say we learned something, and we're going to be ready if something happened in the future. Have a good night. Stay safe.
Thank you, everyone. Stay safe.